Lovely meeting Ankur for the first time. Lovely seeing Diktijaya, Neetu, Neha, and Vineet, and the rest I will get introduced. Welcome all, and it's really wonderful to see and very encouraging that all the effort that we have put in for comprehensive ophthalmologists will be of value to some of us, and we are really looking forward to an interactive question answers from the audience, because we feel in most of the forums the glaucoma specialists start talking to each other and the comprehensive ophthalmologist is lost in that discussion. But this is absolutely targeted for comprehensive ophthalmologists. So it's my proud privilege to introduce Dr. Ankur Sinha, who needs no introduction actually, as my co-host, and I'm Dr. Shuchanda from West Bengal. And we move on to our first talk, where we are talking about IOP. How important is IOP in glaucoma patient evaluation? And I would invite Dr. Orijit Mitra as the first speaker, who is a senior consultant at Ishai Hospitals, and discussant is Dr. Neetu Mohan from Arvind Eye Hospitals, Chennai, HUD. So Dr. Orijit and Dr. Neetu, please. We will invite our panelists to come forward, please. Dr. Alokesh, Dr. Reena Sharma, Dr. Devendra Maheshwari, and Dr. Amit Porwal.
So we do have Dr. Arijit and Dr. Neetu here. Yeah. No, she's not coming. Her mother is not well.
Dr. Orijit, please begin. Dr. Neetu, come here.
So I'm going to start. So it's going to be an interactive session, so I don't have to do much of the talking. I'll just use some facts on the table, and I'll let the panelists and the audience have the interaction. So I've got three cases basically. So this is the first case. So a 45-year-old male presented to us with the complaints of dimness of vision in both the eyes for the past 6 months. So he had a last refractive checkup done 3 years ago. He was apparently all right 6 months, and then he noticed fatigue and pain in both eyes on near work, which is basically a very common complaint that all of us have in our clinics. There was no previous history of use of any ocular medications and no ocular surgical procedures or trauma. He was a diabetic, diagnosed as a case of diabetes for just a year. On examination, the uncorrected visual acuity was 6/12 in the right eye, 6/18 in the left eye, which improved to 6/6 correction in both the eyes. There was nothing out of place on the external ocular examination. When we did the IOP, we noticed raised IOP on both NCT and gap. On NCT, it was 28 in the right eye and 28 in the left eye, whereas on gap, it was 25 in the right eye and 26 in the left eye. We went and did a gonioscopy, wide open angles with ciliary body bands seen 360. CCT was in the normal range of 542 microns in the right eye and 540 in the left eye. These are the disc photos of the particular patient. The presentation was in 2018, so these are the disc photos in 2018. Apparently 0.5 CDR, healthy neuroretinal rim, and no other apparent abnormality. So we went ahead and did an OCT because this is a case where we diagnosed it as ocular hypertension. So just to keep a baseline OCT, we went in and did the OCT. So this is the RT view, opto view OCT. So it was normal. So he was prescribed glasses and a lubricant and a follow-up after 6 months. However, the patient came for a follow-up after 4 years. So after 4 years, the IOP is still holding at 28. So this is in 2022. GAT 24 in the right eye, 26 in the left eye. By this time, we had switched to Spectralis from Heidelberg. So the Spectralis OCTs were again normal. We went ahead and did a perimetry this time because this is a case for sustained raised intraocular pressure or OHD. So the SAP was normal in both the eyes. So I'd like to open the discussion with these questions. What would be your diagnosis? Would you treat this patient? If so, what would be the drug you would use? What would be the follow-up for this patient? Any other investigations? And would you do an OCT GCC or any such thing? And if you find something on OCT GCC, would you treat the patient based on that?
I have a PowerPoint, so shall we complete all the
Okay,
cases?
yeah, we can. Right, that would be better. So this is the first case. So let's quickly move on to the second case. A 61-year-old male presented with a complaint of watering, again a very usual complaint for the past 6 months. Patient was apparently alright and then noticed mild watering in both the eyes. Again, no past ocular history. Medical history, the only positive one was he is a hypertensive for the past 5 years. The UCVA was 636 both eyes, improving to 66 with correction. Apparently, no abnormalities on external ocular examination. Intraocular pressures on both NCT and GAT within the normal range, around 14 to 16. Wide open angles on goniostomy. Now this was the first fields that we did. So this was in March 2030. Now we don't have a photograph of the disc because we don't take disc photographs of each and every patient. So this particular case, the CDR was around 0.75. It was a shallow cup with a bipolar thinning. So when I'm writing thinning on the case sheet, that means I'm committed. I know that this is a case of glaucoma. And these are the fields of the right and the left eye respectively. So once I diagnose this case as a glaucoma case with fields which are corresponding, I prescribe the patient Vimatacross in both the eyes and a follow-up after 3 months. However, the patient continued the AGM for only a month and then stopped. And then the patient presented to us after 5 months. So only 1 month of meds, stopped everything. At that point in time, we used to do a lot of office hour diurnal. So if you look at the office hour diurnal, almost everything is within the normal rate. So we used to make the patient wait in the clinic and measure the IOP every hour. So office hours was okay. But when we did the SAP, we were in for a surprise. So you can see the graph here shows the March 2013 picture, and that shows you 5 months later. So definitely there is an increase in the size of the scotoma, there is an increase in the depth of the scotoma. However, the left eye apparently seemed okay. So now you're having a patient who's progressing, apparently on normal IOPs. So the patient had stopped the anti-glaucoma medications. So the first thing to do was reinstate him on the medications. So he was explained about the need for compliance, asked to continue the Vimatacross, and review after 3 months with all the battery of tests. The patient now went back home, used the AGM for the first 4 months, and then again stopped. The patient came a year and 11 months later, so almost 2 years, with only 4 months of meds that he used. So once you have a patient who has apparently normal intraocular pressures and is progressing, you start thinking that there is something else which is wrong. So we measured the blood pressures. We did an office hour diurnal again. This is after 2 years. You can see the apparently normal pressures. These are the fundus photographs of the patient. Bipolar thinning in a shallow cup. We did a stratus OCT, and you can see that there is thinning in both the eyes. And this is again 1 year, 11 months later. And you can see the appearance of fresh scotomas and deepening of the previous scotomas, and an increase in the depth as well as the area of the scotoma in the left eye. We did a carotid Doppler, we did an MRI MRIs of the brain and orbits, both were within normal limits. Now, when you're seeing this fast progressing patient, sometimes you opt for a surgical intervention rather than a drug. So we advised a trabeculectomy with MMC, and we stepped up the drug. So we used a combination, an FDC bematroprostotimolol. So this is the apparent progression in the patient. This is March 2013. That is 5 months later, and that is approximately 2 years later. So you can see there is a progression in the right eye and a progression in the left eye. So the questions are, what would be your diagnosis? Would you have done anything to treat this patient differently? If so, what would you have treated this patient with? Would you label this patient as a fast progressor? Would you operate? What would be your surgical options? And is MIGS, now that MIGS is any good for this patient? So last case that I would like to present, an apparently straightforward, simple case, a 45-year-old female presented with complaints of dimness of vision in both the eyes for the past 6 months. The patient was apparently alright a year ago, and then she was noted to have high IOP. However, the documents are not available. The patient came and told us in the local dialect that the doctor outside had diagnosed her with raised IOP. So she was already started on timolol eye drops. She was a diabetic for the past 2 years. On examination of the right eye, the vision was 6/24 uncorrected, but it was not improving with glasses or pinhole. And the left eye, it was 6/6. There were shallow chambers in both the eyes. On gonioscopy, you could see occludable angles with pass in the right eye, and you could see occludable angles without pass in the left eye. And the pressures in the right eye were 32 and 20 in the left eye on NCT, and 26 and 18 on gap. So these are the fundus photographs. You can see a large disc with an advanced cup in the right eye. Left eye is apparently normal. These are the standard automated perimeter picture. A very advanced glaucoma in the right eye. Left eye apparently some learning artifact. YAC-PI was advised in both eyes. Timolol pilocarpine combination drop was given, and the patient asked to come after a month. After a month, the intraocular pressure had come down. Both the eyes are almost normal. We went ahead and did an OCT. You can see gross RFL thinning in the right eye, left eye apparently normal, and again the SCP was holding. It's just a month since then. What would be your diagnosis? Would you like to change the treatment? In this particular patient, would you treat the left eye? Already a PI has been done, but no AGM is there. What would be the follow-up? Would you opt for surgery right now? Would you operate the cataract only, or would you go for a combine? So, I'd just like to call.
So, just to sum up, the 3 cases are, one is case of, first case is a case of.
I have a summary.
So, Dr. Neetu will be discussing these 3 cases. Dr. Neetu. Thank you, Arijit, for presenting the cases very nicely.
Thanks, Dr. Arishit, for a very meticulous presentation. So I thought I would just have a slide to summarize each case since we have presented 3 cases now. So the first is a 45-year-old male with a normal disc and a normal OCTR in 2018, and IOP is fluctuating up to 26 millimeters of mercury on gap. And we have a near average cornea thickness of 540. And the second OCT is also normal. These were the questions he proposed. So of course the diagnosis would be of a low risk ocular hypertension in a patient with no family history of glaucoma. First, even at the risk of repetition, I would insist that we have to rule out history of exposure to steroids in any form, because it's extremely common in our population and we need to dig very deep to elicit that history very often. So any form of steroids in the form of topical, nasal, any ear drops, dermatological, systemic, all should be rolled out again and again before coming to the diagnosis, and I'm sure he has done that. So there are no features of virus ocular hypertension like elderly, CDR more than 0.7 in corneas, IOP is fluctuating beyond 26. Any suspicious changes in the OCT we should be for a vein occlusion. discuss options with the patient and take an informed decision depending upon access to care, how keen he is to be on treatment, everything to be considered. And my suggestion would be to observe the periodical review and follow up investigations yearly, or if the patient is anxious, even every 6 months. Since he is relatively young with borderline intraocular pressures, I may suggest a diagonal variation of IOP just to see how much the pressures are fluctuating, especially the early morning pressures, but not absolutely essential. My first choice of drug, if I have to start, that is, if there is poor access to care or if IOP is fluctuating beyond 26, would be latanoprost. And if consistently elevated intraocular pressures are proven on multiple visits, then probably SSLT is also an option that can be suggested. OCT, GCC, yes, definitely, that is additional information for follow-up. It is good to have as much data as we can get. So the 5-factor model which is proposed by the old study is older age, higher IOP, thinner CCT, larger participation, and higher visual field pattern standard deviation to predict conversion of cochlear hypertension to primary open-angle glaucoma. And as we know, CCT is also an independent risk factor, and for the Indian population, this CCT is around average. So early medical treatment reduces incidence of primary open-angle glaucoma by 60%, but this benefit of treatment is of greatest benefit is in the high-risk ocular hypertension. There is little absolute benefit in low-risk ocular hypertension, so we need to choose the patients whom we are going to treat. And structural and functional testing is of course very important. The old study did not have the patient's OCT data on for follow-up. So since we have OCT also as a valuable tool now, both structural and functional testing would be necessary at every visit. So coming to the second case, so we have a 61-year-old male patient with early cataract and some suspicious disc changes. Of course, he said that he has committed that this patient has glaucoma since there is definite bipolar opinion. But I would also like to have a little more information on the retinal nerve fiber layer and EPA. There's some additional data to follow, and of course, as he suggested, fundus photographs also will be useful for follow-up. And this first HFA in the right eye is a borderline refractive case with especially high fixation losses. So you need to consider that this is a borderline reliability field, but yes, there are changes in the HFA which could be suggestive, and it corresponds to the inferior ring thinning which is seen on the fundus photograph too. Left eye is a better reliable field, and there are some early changes in the inferior ring field, and OCT corresponds to this. Bimatocross was prescribed to this patient, and follow-up was suggested after 3 months. Here again, I may differ a bit in the drug of choice, since bimatocross, considering the tolerability, effect on the conjunctiva, the local side effects, outcome of a future trabeculectomy. So brimonidine, butazolol, or latanoprost in that order would be my drugs of choice in a patient with NTG. And I would also probably review a little earlier when I first start on a drug, just to rule out any possible side effects or how comfortable the patient is, the technique of drop instillation and all that is considered. And the diurnal variation when done, the IOP fluctuated only up to 14 millimeters of mercury. So of course, at this point of time, the patient had stopped medications. HFA, again, right eye is of borderline reliability, but probably there is some change happening in the right eye. Mean deviation has also dropped. 1 year and 11 months later, assuming that the patient is on bimatocross at this point of time, again, there seems to be absolutely no response to bimatocross. IOP is still fluctuating around 12 to 14 millimeters of mercury. And yes, mean deviation has dropped. This the first, considering that the first two are the baseline test, this is the another test where there is a definite change in the visual field. We still need 1 or 2 more tests to make sure that this change is reproducible. But yes, there is a drop in the mean deviation, and also there are some changes happening in the left eye. And that more concerned because changes are happening very close to fixation.
एनालिस्ट अभी
Diagnosis
करने
would
के
be
लिए बोल देते हैं,
non-attention
नहीं तो
glaucoma,
बाद में
which is properly
वो इन्वॉल्व
processing
नहीं होना
on
मुश्किल
medical
होता है, अभी
management. We
इसलिए
need
एक एक
1
करके
or
टैग
2
करते
tests
हैं.
more to prove that.
पर अभी पैनलिस्ट
My
भी तो
first question would be regarding compliance, because the patient is on bimatocross and we are seeing absolutely no response. So first question would be how compliant is he? What is the technique of drop instillation? Is he doing it himself? Is somebody helping him? If all that is taken care of, 24-hour blood pressure monitoring could be suggested to rule out a nocturnal dip in the hypertension, because dip in the blood pressure, because he is on antihypertensives. We need to rule out overtreated hypertension. We need to consult with his physician. Obstructive sleep apnea syndrome to be ruled out. Ocular blood flow analysis can be changes in clinical management is not very clear. Treatment, as I mentioned, brimonidine, betazolone would be my first drugs of choice. Is he a fast progressor? As per the data that we have till now, probably yes. We have had a decline of 3.2 decibels over 2.5 years. But it would be better to confirm another test even a little earlier, maybe after a month or 2 months, to be absolutely sure of that. Currently, I would suggest medical management with very close follow-up with structural and functional testing. If there is a definite progression, a glaucoma surgery can be considered. Considering that he is relatively an elderly patient and early cataract is there, could be an option for this patient if a surgery is indicated. Case 3 is a 45-year-old female patient with definite cataract in the right eye, early cataract in the left eye, very high pressures in the right eye. A AIOC has been done and the patient is currently on Himalol, Pilocar and Bimatoprost in the right eye. Pressures controlled, but advanced glaucoma in the right eye. Diagnosis would of course be primary angular closure glaucoma in the right eye and PACS or query PAC since we don't know the baseline pressures in the left eye post PI. I may not consider continuing pilocarpine in a 45-year-old on a long-term basis considering the side effects and induced myopia. I would withdraw pilocarpine. Bimatoprost again may not be my first drug of choice since it is unilateral treatment in a very young patient. It can cause a lot of local side effects. The effect on a future combined surgery. Bimatoprost I would not give unilaterally in a young patient for a long time. UBM is an option that can be considered to rule out severe body cysts since she is relatively young. Left eye could of course be observed for right now. Right eye surgery, I think that is the only question that we need to really, the rest of it is quite straightforward. Right eye, we have the option between a combined trabeculectomy with a cataract surgery versus a cataract surgery. So all the data which we have, as of course, literature suggests that very controlled primary angular glaucoma, medically well controlled, even a cataract surgery would do fine. But since she is relatively young with more than 180 degree of pars, I may still consider a combined surgery, but the decision will be taken in consultation with the patient. Thank you.
Thank you, Dr. Nita, for an extensive discussion. So I don't think we will have a panel discussion on this, and we move on to the next set of questions. And for the audience, we will take up all the questions at the end. Please keep your questions ready. So, introductory slide.
So I would invite Dr. Digvijay for his talk. Digvijay will be talking on red or green. Is it true? So
Just a moment. Yeah, our introductory slide.
yeah, Dr. Digvijay is from Gurgaon. He heads the Noble Eye Care and he's the head of the department for the Narayana group of hospitals for ophthalmology in Gurgaon. And he'll be talking about OCT, and we will have a discussion. Dr. Subhashini with us. Dr. Subhashini is a professor at the Zipmer Pondicherry, and she'll be a discussion for this. So I think let us start with the talk because
Yeah, the introduction has already been done. This is Dr. Digvijay Singh. Thank you, Digvijay, for joining our session. And the
Next slide,
discussant is next. Dr. Subhashini from JIPMER. We are very fortunate to have her as our discussant in this case. We will request that we maintain time in our talks and discussions. Dr. Digvijay, please. Next.
उनका लगा दो. You have a pen drive?
Yeah, she's loaded hers.
how the structure and the function correlate. The other I'm going to be talking about is red disease, green disease and red disease, and I'll come to what these essentially are and what they exactly mean in three very brief cases. So this is where the role of OCT glaucoma gets highlighted primarily, but we have to take it to the visual audio to understand how to interpret it. So this is a case of a middle-aged female who's also myopic, is having increased cupping in the right eye. You can see that there is a superior rim thinning, there is a slight notching, some peripapillary atrophy in this area. The left eye optic disc also appears suspicious with a slightly large cup, though much lesser than what it is in the right eye.
रोकने होगा उसका 50 स्लाइड से ऐसा कुछ
The left eye as of now is not showing any effect on the visual fields. On the OCT, you can see that the OCT in the right eye is showing a thinning in the superior and superior temporal quadrants, and the left eye is also showing some thinning there in the RNFL, while there is no effect here on the visual fields. So the impression here is that the right eye, the OCT, the structural change of the OCT is corresponding with the functional change on the visual field, and that's typically what we expect to find in cases of glaucoma. In the left eye, we could see that there was changes in the structure in the OCT, but the function on the visual field was normal. So this kind of goes into a pre-perimetric glaucoma picture. So OCT changes can precede the changes on the visual field, but in most cases, structure should correspond with function. Now let's look at another case here, and this is what we call as green disease, where you're getting a change in the optic disc in the right side. It's a disc which is appearing glaucomatous. The left side disc is appearing more or less normal. You can see that there is an inferior arcuate, typical glaucomatous field defect in the Gerens area here. The OCT is showing very slight borderline change, if at all. A lot of times this may actually also be green, but mostly at least a bitter yellow does come about. But compared to the same field defect, if you remember in the previous case, the OCT was showing a bright red couple of quadrants there. So that way this OCT is relatively preserved compared to what is happening here on the field defect. And the left eye, of course, seems to be doing okay. So the impression here is that this is what we call a green disease, where you are getting a definitive defect on the visual field, you're getting a definite change in the optic nerve, but the OCT is relatively preserved. So it doesn't necessarily mean that the OCT has to be affected or you have to see a change in the OCT for a case of glaucoma. Let's move to the third case, and this case is a case of a high myope, who's having some peripapillary atrophy, cupping in the range of about 0.5 or so. The visual fields are more or less looking normal. The OCT is showing changes. There is something in the RNFL. You are getting some red segments there, and in further advanced myopia, you can actually have a lot more red as well. But I've kept those cases that you would typically tend to see. And but here, this is actually the redness of thinning that is coming in the retinal nerve. There is actually an element of myopia, and not really because of glaucoma. So this is known as red disease, where the OCT may show red, but this is not glaucoma. This is because of myopia. And you can see here when the HRT was done for the same patient, it was coming to be completely normal. So these are the three basic cases. You can have structure correlating with function. You can have changes in the structure preceding changes in the function. You could have no changes in the structure yet have changes in the function, or you could have changes in the structure but the risks are not glaucomatous. It's not glaucoma. That's completely wrong.
Thank you, Dr. Digvijay. Now I would request Dr. Subhasini to discuss these cases, and then we'll ask Dr. Reena to add up something, or for general ophthalmologists to basically, Yeah, Dr. Reena is with us. She's an associate professor at the Medical College of Sciences at Etawah, Uttar Pradesh. She has come all the way. So please load Dr. Subhasini's presentation.
Good morning, everyone. So I will be discussing the three cases which Dr. Digvijay has shown now. So before that, let us quickly recap how spectral domain OCT printout looks like, and how you will be interpreted. So this is the CIRRUS HU
Last
thickness
day
map, and then the other is the thickness map of the left eye is here. So here, this is not compared to a normative database. So don't look at the colors. So actually red here means it's thicker. So you have to look at the pattern. It's a bilaterally symmetrical butterfly pattern that you get. Then below the thickness map, you have the deviation map, and so it's deviation. So it compares with the normative database, and then it gives gives the colors. Yellow and red superpixels demonstrate that RNFL3 is there at the 5% and 1% deviation cutoff levels, respectively. And below here, you see the tomographs. This will give you an idea of any segmentation errors. So this will map that RNFL. And then in the center part, at the top, you have the table which shows the values between the right and the left eye, the symmetrical pattern. And then below that, you have the Tisnet graph for the neuroretinal thickness, and below that, the Tisnet graph for the RNFL thickness, then the quadrant values, and then you have the Glaucoma values. So this is how you go about reading the OCT printout.
It's not moving.
Sorry about the technical issue. Yeah. So in the first case that Dr. Vijay presented, so it's a middle-aged female, a myopic patient with large disc and cupping the superior notching here, and corresponding you see a inferior defect. Okay. And then in the OCT picture, you can see the superior the quadrant. You can see the red pixel being flagged as red, and here also you can see the red area in the superior part. So this kind of correspondence is what we look for. So whatever this changes, what you see, is it reflecting the fields and corresponding the OCT defects, are they seen? This is what you look for.
It's not moving again. So
Change it from your podium.
उधर से बदल दीजिए.
आपका पोडियम से बदलते रहिए जैसे मैडम बताते हैं.
वहाँ से भी नहीं चल रहा है.
So in any case, you have to always look for the structure-function correlation. So we are looking at, you have to look for the real disease, not just simply look at the colors red or green. So any changes in the visual field should be correlating with the changes in the optic nerve structure in a pattern which is compatible with glaucoma. So what is green disease? Green disease, simply put, it's a false negative OCT. So meaning to say that the patient would be harboring the disease, that is, would be having glaucoma, but it is flagged as normal. So there could be several reasons for this. One, it is acquisition dependent. It could be because of the operator or patient-related factors. So in defocusing, it's not focused properly, or the scan circle is decentered. Then the other reasons could be disease related. Early glaucoma, in which the RNFL thickness is within normal. So as you all know, it compares to a normative database. Though there are changes in the RNFL thickness, it might not be reflected. It could be within that range of the normative database, and hence it would not be highlighted. Then instrument dependent head tilt also can cause variations in the RNFL thickness. So in a second case, this demonstrates the green disease. So you can see in this picture the superior notching, and also in this photograph you can see even superior RNFL defect and a corresponding inferior visual field defect. In the left eye, the cupping is around 0.5, the ribs are healthy, and here there is some defect which is seen. But in the OCT, there is only a mild change. It shows as yellow, and in the left eye, it's completely green. So though there are significant changes in the RNFL in this photograph, as well as the field loss is seen, but this is not reflected in this OCT printout. It shows it just highlights as yellow, which is borderline. So this is what happens in early glaucoma. So sometimes you might not see these changes in the OCT. Some early glaucomas, you would see the changes in the OCT, but you might not see the changes in the fields. Here in this case, the field changes are seen, whereas in the OCT it's appearing normal. The next is red disease. So red disease, simply put, it's a false positive OCT. So the patient is, despite being healthy, he or she is flagged as abnormal. So what are the reasons for these? These are mainly because of segmentation errors. Eye movement or blinking, these all patient-related factors can result in this. Then sometimes there's a horizontal shift in the contour peak that can also cause this. High myopia is a very important cause for red disease. And poor signal strength, media opacities can result. And nowadays, this multifocal ions are being used left and right. So these very horizontal artifacts also can give you a picture of red disease. So in the third case, it was a high myopic patient who was suspected as having GOAG. And here you can see the large discs with the cupping, though the rims appear fairly okay. And the field is showing a small defect superiorly in the right eye. However, the left eye is normal. But if you see the OCT printout in the right eye, you can see the red pixels about in this quadrant. It's flagged as red. So, but there are no changes actually in this photograph or in the fields to highlight this. So this is what happens in high myopia. So high myops usually have a large disc, and actually their baseline RNFL itself is thinner, and because of which the values, it's flagged as red, and higher the axial length, the more chances for the RNFL thickness to appear in a much thinner. And moreover, even the bundles, the RNFL bundles, sometimes when they attach to the disc, they could be temporary, they could be shifted temporarily, and because of which you have this kind of a red disease. So basically, this patient doesn't have glaucoma. He has to be just followed up. So the take-home message I would like to say is OCT cannot be 100% specific. It's true for any other machine. So I'm 100% sensitive at all times, because these devices, they have biological, engineering, and biophysical limits. So as clinicians, we need to understand the limitations of imaging technologies. And so in a busy clinic, you just simply don't look at the OCT and make a diagnosis based on the colors.
Thank you, Dr. Shubhashini, for a complete discussion. We would like to ask Dr. Reena Sharma, please come to the podium, please, ma'am, that sometimes over-testing a patient leads to a lot of confusion, as we have found out the red disease and green disease. Where exactly would you advise OCT RNFL in your clinic practice?
OCT is definitely an investigation that could help, especially in early cases of glaucoma, if we are suspecting the disease and the fields turn out to be normal. But otherwise, also, even if we are getting a green disease on OCT, what I feel is a comparison of the thickness maps of the two eyes can always give us a clue as to where the thickness may be below normal, even if the quadrantic maps, the glaucoma maps, and the distant graph is giving us normal values.
Are you using OCT GCC in your regular clinic practice? Glaucoma, that is GCC, is ganglion cell complex.
Analysis. Not in all cases, but yes, in cases where I'm not getting to a conclusion as to whether I should start treatment, especially in ocular hypertension and early POG patients.
I can just add one more thing, like sometimes the baseline nerve fiber layer of the patient is higher, and if it decreases from that level, but if it is still in green levels, it is significant for us. So OCT does have, as Dr. Reena has said, that has an important value in documenting. But if we have a normal, then higher than normal thickness, which reduces over a period of time, is an indication of nerve fiber layer loss, even if the color doesn't change, because color usually has statistical values, but we are looking at a patient, not at the statistics.
I forgot to add that point, especially in high myopes, you can do a GCC. That would be helpful, especially when they have a large temporal and a nasal present. In those cases, GCC sometimes shows up if the macula is
Yeah.
big. And in the normative database, the high myopes are not represented at all. So because of which the comparison would not be, it's difficult. So as Dr. Ankur says, a serial OCT and just look for the change in the RNFL
So the
thickness.
same thing happens with myope also, ma'am. Like if there is a progressive thinning, then we may think in terms of something is happening. If it is still the same over a period of say 1 year or so, it can be considered as low. It's okay with us.
Dr. Amit?
So-
So as Ankur was saying, even if it is the RNFL thickness is in green, but if you have done the OCT on day 1 and after 1 year, if you are doing the OCT again RNFL, if there is thickness is reduced by 10 microns, then we have to think that there's something going on.
Yeah.
It is significant, even though the RNFL is green. So
Yes.
don't go by the colors, go by the matrix, which is very important.
Yeah, I think 10 microns is
thank
the
you.
cutoff limit. Sometimes even dehydration causes decrease in the nerve fiber layer thickness. So you have to be careful, especially in Kochi.
Thank you, Dr. Reena. So the one important take home for comprehensive ophthalmologists, I feel, as the end result of this discussion is that do serial mapping wherever in doubt, and don't jump to treatment because it will take time to deteriorate. Glaucoma just does not go into blindness overnight. So take your time, follow up the patient, and then take a call. And another thing I learned today, that multifocal IOLs can give false
Issues.
RNFL
Yes.
issues.
Yes. So next we have Dr. Neha. She has come all the way from Delhi. She is director of Avantika Eye Care Center and Glaucoma Care in New Delhi. And we have discussant as Dr. Vineet Sehgal. Dr. Vineet is a senior consultant at Sharp Eye Centers at New Delhi. And for this, we will be taking Viva of Dr. Alokesh.
Dr. Alokesh.
Yeah, Dr. Alokesh is a consultant at Premvada Birla Arvind Eye Hospital at Kolkata. So, so Dr. Neha, please. So,
So, thank you, Dr. Stranda. Thank you for involving me in this session. So, I think a lot of it has already been talked about, but still, I'll show some of the cases of pending. It's not moving. Yeah. So whenever we see a field, we ask to ourselves these basic questions: is it reliable? Is it normal or abnormal? If it is abnormal, what is the cause? Is it glaucomatous? Any other optic nerve disorder? Any retinal pathology? Any optical media opacity? And does the report correlate clinically or not? Also, we have learned over the time that we have to, for a field test to be reliable, you have to be sure that your false positive, false negatives are not more than 33%, and your fixation losses should not be more than 20%. So whenever you look at a field, never be in a hurry to judge it by how black it looks. Always carefully evaluate that you are looking at the correct patient, that ADEM has been entered Now again, look at the first field. Looks very looks like advanced glaucoma. As the time passes, and with each successive field, the fields keep on improving and improving. So this is a typical learning effect that is very much prevalent, especially in in a subjective test like this, where patient is pressing the buttons. Patients are mostly aged, so they eventually learn how to do the fields. So again, you should have your base is looking bad, corroborate whether your disc is actually that bad or not. So if you feel there is some difference, always repeat the visual fields before you start any treatment. Now this already been discussed, but this is a typical case of pre-perimetric glaucoma. You see a RNFL wedge defect corroborating on the OCT, but the fields are normal. So it is a pre-perimetric glaucoma. So a normal field will not rule out glaucoma. Now, just few cases. So here you can see inferiorly a wedge defect, corroborating to which we have a early superior arcuate scotoma. And as the disease progresses, this is another case where you see that the inferior rim has been totally lost. There is an inferior notching, and hence the scotoma that you see in the superior field is much more deeper, and it is a dense superior arcuate scotoma with a peripheral spread. Then when both rims are lost and you have a near total cupping, you see a arcuate scotoma in both hemifields. Again, the point what other speakers have also been emphasizing, it is all about corroborating all the factors, your disc, your fields, and OCT. Then coming to some non-glaucomatous cupping. When will you suspect a non-glaucomatous cupping or non-glaucomatous changes? When you feel your vision loss is not consistent with the disc changes, there are some neurological signs also, and your visual field loss is not compatible with the diagnosis of glaucoma. So this was a 52-year-old female patient with gradually progressive bilateral diminution of vision. Vision was 660, 624. We know even in advanced glaucomas, your central visual acuity is preserved. So you have to be thinking on some other lines. We did the visual field. This is what the picture was. It was a bitemporal hemianopia. And on the imaging, we found a pituitary macroadenoma. So made a diagnosis of compressive optic neuropathy. Then again, another case where a 55-year-old male truck driver by profession, history of hypertension, sudden decrease in vision in 3 to 4 days with some generalized weakness. Fundus was appearing to be pretty normal, and this is what you see. It was a right homonymous hemianopia. On MRI imaging, we found a cerebrovascular accident. So these things have to be kept in mind. So my take-home message is that when reading a report, it has to be correct patient with correctly entered age. The field has to be reliable. Most important thing is that it should corroborate with your OCT and your clinical findings of the disc. Never be in a hurry to start your treatment. Normal field does not rule out glaucoma, and abnormal field does not confirm glaucoma. So there are machines, but there is a man behind the machine. You have to apply your brains while interpreting any results of any of the machines. Always rule out other non-glaucomatous causes. Thank you so much.
Thank you, Neha. I'll invite Vineet to add on to something for the discussion. Come on the dais, Vineet, please.
Yeah, please be here only.
Vineet is a good teacher for a lot of residents.
So I think Neha has done everything and nothing much for me for the discussion. For the general ophthalmologist, what is the take-home message that I would basically tell is that our fields are automated, but our patients are not automated. So our fields are automated, but our patients are not automated. So most of the time in our practice, my patient would say that, sir, I would not like to go for a field, but I would like to go for an OCT. It is very easy for him. So we have to tell the patients that, sir, this is very important for two reasons. First is to know that whether you are having a glaucoma or you are not having a glaucoma, because counseling is very important. As they have told us that there may be a lot of defects, and if you just give 2 minutes time to your patient before he starts a visual field or any test, your results would be much better. So this is the first thing. Second thing is that always interpret a visual field in total. It's not something which would basically make a diagnosis. It is a tool. Dr. GC always says that the diagnosis has to be made by the clinician, and these are all the supplementary tests. They should not basically, we have not to, as a private practitioner, we should not order the battery of tests only because now we want to make a diagnosis of glaucoma. Yes, we are having a diagnosis of glaucoma. We are basically having in two minds. That's why we are doing. And second thing is for always think that any visual field, if you are getting a visual field defect, it is not that 100% that these visual field defects are because of glaucoma. They can be because of other reasons also, as Neha told us that there can be visual pathway lesions. So go back to your Khurana, go back to your past and see that which type of pathway defect can basically, you can have congruous lesions, you can have incongruous lesions. So go back, and I would say every practitioner should, who is having a visual field, who is ordering a visual field, at least once in 6 months, they should have a basic anatomy revision of the visual pathway, because that is very, very important. And last but not the least is that always think a patient as a total, because if you are making a diagnosis of glaucoma and starting him on any medication, remember this is a lifetime stress to the patient. So always be very, whenever you are getting the test done, after that please give 5 minutes to the patient and tell him that why this is important, what is the interpretation. Always write your own report, and because you have to tell the patient again for your sake and for the patient's sake that you have to come again for getting this visual field test. Thank you.
Wonderful, Vineet. And what I really think is a big take home message to everybody here is the human touch that a glaucoma specialist needs to have, rather than going bang and saying, nahi, nahi, isse acha nahi hoga, ye rahega. For us, it is just a statement. For a receiver, it is not merely a statement. I would request Dr. Alokesh Ganguly to come on stage and give an idea to the comprehensive ophthalmologists when to order a 30-2, when to order a 24-2, when to order a 10-2.
Just I would like to add that it's a team between you, the perimetrist, and the patient. Because when the patient is not doing well, your perimetrist should intervene early and come back to you. That's how the patient is not doing properly. Then you have to call back the patient and make him understand that all points would not be seen, and it's not a test for your proficiency. I mean, you just don't have to score marks here. It's the test of reality, and it's like you're running a 100 meters race with your best capacity. So you don't need to just time like a Ben Johnson. It has to be, kind of your own pace.
And
so allocation.
We've seen the opposite in our high volume hospital.
Yes.
When the patient comes and tells me the perimetrist was continuously on the phone talking to somebody, so I couldn't concentrate.
I think wonderfully covered by both Dr. Neha and Dr. Vineet. But one thing for the general ophthalmologist, just I noted the first series of tests which she showed, in which there is a gradual improvement and learning. Always be sure to have the best field reset as your baseline when you are judging progression. Don't do that mistake, because if the baseline is taken as the first fields, which was a huge learning curve, defects was due to the learning curve, then your progression will not catch up. That is one thing. The other thing, as they said, that is you have to think beyond the optic nerve. From my experience, I can tell you have to look at the whole of the fundus. And sometimes I have seen specifically glaucoma specialists also concentrating too much on the disc and not looking at the peripheral fundus. For example, I don't have the slides with me, but you have a typical inferior notch and a typical superior arcuate scotoma. And when you look carefully down the arcade, you find that there is a retinochoroidal coloboma. And these patients have been treated with glaucoma drops. So, it's not only beyond the optic nerve, but also anterior to. They don't look like Arjun as the eye of the bird. Look at the tree also, right?
Yeah.
So, as to the question, I think for a simple rule of the thumb, as there was one case in which there was a young patient on OHT, the earlier presentation with a very peripheral early fields which are being defect, which is being caught on 24-2. In these cases, maybe you can go for a 30-2, and maybe you can also go for any patient in whom you are suspecting pallor of the optic nerve of typical delineation, which makes you suspect a neuro-ophthalmological disorder. 24-2 we are routinely doing, but now 24-2C has also come, which you can also integrate the 10-2 with it. But definitely, if in the 24-2 there is a threat to fixation, or fixation is involved in one quadrant, you should definitely go for a 10-2 and use that 10-2 for a analysis of progression. Even if the 24-2 shows progression, you should technically specify that the 10-2 has to be repeated, and you compare and whether you can stand that progression, because that is a more generalized version, is more specified version. This may help you to judge whether there is a long-term fluctuation or whether there is actually a progression in the case. Thank you.
Uh, Thank you, Dr. Alokesh. So next we have is talk by Dr. Avik. Can I have slide of Dr. Avik, please? Dr. Avik will be talking on decoding the suspense of the suspicious disc. So there's too much of suspense for Dr. Avik to solve. Dr. Avik is a consultant at Glaucoma and cataract services at LVPI Bhubaneswar. The discussant would be Dr. Dipanjan. Dr. Dipanjan, slide please. And Dr. Dipanjan is Dr. Dipanjan की slide लगा दो. Dr. Dipanjan slide please. Yeah, Dr. Dipanjan is a senior consultant for glaucoma and cataract at Disha Eye Hospitals from West Bengal, Calcutta. And for this, we'll have a public viva of Dr. Amit because he'll be the expert panel here.
So,
Dr. Avik, please.
Thanks for the introduction. So let us decode the suspense. So I want all of us to become Sherlock Holmes after today's this short presentation. So the basic idea is to arouse our sensitiveness in differentiating different types of discs. So I will give you two examples of like a 24-year-old young male patient with good vision, with normal IOP, with open angles, totally normal fields with disc like this. I think there is no doubt in everyone's mind that this is a normal case, normal patient. And if on the other extreme, if we get a patient like 76-year-old female patient, a housewife who is having a very little bit poor vision with a very high IOP of 46 with angles totally closed, significant cataract, advanced field damage with near total cupping, I think it's also, we have no doubt that it is frank glaucoma. So here we don't have any confusion among the comprehensive ophthalmologists to differentiate between these two entities. So confusion arises in other cases. So I think all of it has been already been told several times that the ISNT rule is very important. But if you follow the ISNT rule only, you will be correct in 90% of the cases. So you have to follow other tips in addition to the ISNT rules so that you won't miss those 10% other cases where things can change. For example, this was a case, 30-year-old male patient with normal vision was labeled to have glaucoma, and then started on medications, and patient was very depressive, and he came to us for a final opinion. But actually, I think if you dig it further, it will be a physiological cupping with large disc and large cupping. This is where the first mistake that happens. So we tend to forget the disc size. So you know that the disc size, the size of the disc increases, the cupping also will proportionally increase without causing any more problem. So all these things like small, medium and large size disc will have small, medium and large cupping, but all these three are essentially normal. So this is the mistake number one that can happen. So mistake number two that again can happen the young patient, 40-year-old male patient. So apparently disc is normal, ISNT rule is maintained. So it is very good, very nice. We go for the fields, it's also good. So we assume that it is normal, but we are wrong because we did not look at a wider angle. So if we see little wider, the fundus is showing a superior wedge-shaped RNFL defect that is also more prevalent, more clearly seen in the red free. So again, this could be a miss from the general point of view. So this is the preperimetric glaucoma. So this is how we can we can detect the RNFL defects. So if you can compare the normal patient with the normal bright shiny RNFLs at both the poles, and then the RNFLs will show a slight loss of their shininess to look little dull, and that the thing that we shouldn't miss. So the last case for today from my side will be a 30-year-old female patient with she had been had a -8 diopter of power. She underwent LASIK 8 years back, the very thin cornea. She was also labeled with glaucoma just because of these findings, so that any large side disc with thin rims with peripapillary atrophy can have some changes on the OCT, and then based on these two things, one might diagnose to have glaucoma. But actually, it's not true because this was fields being normal, so this is a myopia, not glaucoma. So to conclude, I like to again re-emphasize the same thing, that we need to decode the suspense by bringing into piece the different informations like the IOP, the angles, the disc and field into one single puzzle, and then you can solve the jigsaw puzzle. Thank you.
Thank you, Abhik, for a very good presentation. Now we would request Dr. Deepanjan to come up and discuss the case.
My slides.
Put Dr. Deepanjan's slide, please.
Yeah, we'd like to decode the suspiciousness from the words of Dr. Watson. So, first, any rule. Like this paper beautifully, it tries to validate the ISNT rule in normal population and found that this rule was valid in only 37% of the REM assessments and 43.8% of the RNFL measurements. What they found was a nasal REM was the point of problem. So if you remove the nasal REM, exclude the nasal quadrant from the rule, it significantly increased the validity of the ISNT variance to the tune of more than 70%. But to make this a little less complicated, it is better to go with the Weintraub's rule of 5 R's. It starts with to observe the scleral ring, to identify the limits of the optic disc and its size, and try to identify the size of the rim, examine the retinal nerve fiber layer, examine the region of peripapillary atrophy, and look for the retinal and optic disc hemorrhages. In some cases, like this picture at the left, it is very, very obvious where it is actually the bayoneting is happening, and the curve, the nasalization, the changes of the vessel, but not like the picture on the right hand side, where sometimes we call it as contour cupping. You look very carefully, you can see the subtle change in the vessel. Detection of disc hemorrhage is of extreme importance, as in this landmark studies it is seen, it is clearly associated with disease progression. But on the other side, we also need to see that follow-up is equally important. And in this case, this disc didn't show progression almost for 8 years. So this is probably a case of infarction of the optic nerve head that is sometimes associated with some vascular pathology. And so it must be evaluated in context of other predictive factors. Glaucoma often shares features with other optic neuropathies. So it is like an altitudinal defect in AION or an central scotoma in a toxic optic atrophy. So we very specific about taking care where the patient is having an afferent pupillary defect, acuity of vision. Please remember the glaucomatous patients, they retain their color acuity for very long time. See regarding the pallor of the preserved rib and typical characteristic visual field defects also Meda has said earlier. Myopia poses a special risk, the special problem, and it comes with anomalous nerves, anomalous visual fields, mostly with normal pressures, and there is a pressure from the publication houses that there are several population-based studies have shown association with high myopic refractive error. So we are positively biased. So what we need to do is see the worsening of visual fields, look for an elevated IOP if we can find, and then start medication. And of course, we need to see the additional risk factors the patient can have. This is a very interesting scenario. We actually found it in one of our ophthalmologist friend, and these are typical pseudo RNFL defects which are found in very high myopes. And it is postulated that the number of the axons are insufficient to cover the enlarged posterior segment of the myopic eyes, which comes as an oblong shaped cracks in the vessels. So don't get confused about this with a normal RNFL defect. Thank you for your kind attention.
Thank you, Dr. Deepanjan. And I would invite Dr. Amit to add up his point of view about disc assessment for general ophthalmologists.
They have covered everything. Avneet and Deepanjan has covered everything. Only suspicious disc, what I would like to tell you is keep in mind the size of the disc. The small disc, the medium sized disc, and the large disc is very, very important. Keep in mind the peripapillary area also in high myopes, because this is going to give a guide. And all the parameters which they have mentioned, we should take into account. I have nothing more to add in this.
Yeah,
It was a lovely discussion.
I think we should develop a habit of having a assessment of disc on a 90D, because sometimes the assessment on an ophthalmoscope may not give you that much of clarity of contours. But yes, ophthalmoscopes gives you a very fast assessment of the size of the disc, as Dr. Amit mentioned, because you can just fix the middle circle over the disc, and if it is smaller than that, it is small; larger than that is large. Yes, Dr. Vivek, you want to add something? Yes. Can you come on the mic, please? Because
yeah, how do you differentiate pseudo RNFL defect? I could see that they were along the vessels. So is it like they are not always along the vessel, or?
Yeah, pseudo RNFL defect, what we have found is it is actually it was eye opener for us. We were actually trying to treat this man. He was our oculoplasty surgeon at Bellevue Clinic, and he was a very high myop. He was using minus 18. He's there with you, I think. You can see his retina and find out. So we were confused. Probably he has a family history also. And then we found actually Alokesh should get the credit, because he took out, he did all the literature search, and actually we got to find that there is something called pseudo RNFL defect. Till that time we were unaware about it. It was 2007-8. And then what we found is these are oblong shaped cracks, and they usually appear just under a vessel. So this is just under a
can we show that photograph, please? Because it's interesting, because you have to understand that, very rarely you will find such a picture, a clear picture.
It is exactly like a
Dipanjan, the question
And
was
also,
do you think
I think that it is.
In that paper, that it is not only by the it can also be the side of the vessel, but it will as you move away from the disc, it will not flange out.
Yeah, that's what I was about to say.
Spindle shape.
Yes, it will keep the same thickness as it goes away from the disc.
No, actually it will not flange up, it will actually close. Because it is like the eye is having a ballooning effect.
Okay.
So it will appear like a spindle.
So they
Because
are
to me it was looking like not flagging out, so I was thinking, since it is not flagging out, probably it's not an RNFL.
This pseudo RNFL, basically they are below the vessels, but they don't have origin near the disc. That is very important.
Yes.
So Dipanjan, they don't have the origin at the disc margin. That is important. We just
It can originate the disc margin also.
But in this case also.
Yeah,
you
this
see-
one.
Yeah.
Look at this.
So it is not at the disc margin, classic broad shape, and then widening out.
It's starting little away from the disc, but yes, I agree. It's not going further from there. Look.
Yeah.
After the vessel
But
bends
it
down.
is it is a real look alike.
Yeah.
You can really get confused.
See at the primary crossing, it is actually beginning to converge. It's hiding about it.
It's a picture worth publishing to make people identify these kinds of defects. So yeah, that's okay. I mean, but it is good for learning. It's very good for learning. Yes, definitely.
What we say usually is that the whole defect is called a wedge defect.
Yes,
Because
it spreads out.
This one doesn't usually have any particular form or shape. Sometimes it can just be a band. Sometimes it can be like a spindle, which tapers in both directions. It doesn't have a particular shape.
Yeah. So I think
consensus is this is a very interesting picture. Dipanjan, Alokesh, you should send it for the picture essay.
Yes.
And you should send it for case report for publication. Don't just put it in the WhatsApp group.
So yeah.
10 years, 15 years.
Yes. So let's do that, because this is going to really help a lot of people. And I think with the paucity of time, I think we should move on
Dr.
to the next.
Siddharth.
So we have Dr. Siddharth. Can you put Dr. Siddharth's slide? Dr. Siddharth is a consultant at the Glaucoma Care Center at LVPI Hyderabad, and discussant here would be Dr. Ganesh Raman. Can we have Dr. Ganesh's slide, please? Next slide. No, Dr. Ganesh.
Introductions.
Yeah, introduction. Dr. Ganesh is head of the glaucoma services at Coimbatore, Arvind Eye Hospital, and we'll have discussant as if Dr. Devinder comes, or else Alokesh and Amit will be here. Yeah, panelist will be. So, Dr. Siddharth, please.
Thank you, Dr. Ankur, Dr. Suchanda, for having me here and giving me a topic and a discussion that I really like. So I'll be talking about some common situations which reflect the importance of looking at the angle in any practice, not only a comprehensive ophthalmology practice. And these are the three scenarios that we will try to look at. I will look at the time and then see where I need to stop. The usual suspect is not something that we don't commonly see. It's a very common thing. And this is story about a 42-year-old homemaker who came for a general checkup. They become presbyopes by this age, can't read, can't do a lot of things. And everything about her was quite okay. She was a hyperope and the anterior chamber depth was shallow, which basically means that when you go make an optical section, go to 60 degrees and look at the peripheral most cornea, the anterior chamber depth was the thickness of the anterior chamber was less than half of that of the peripheral cornea. And this is a situation when you need a gonioscopy. Upon gonioscopy, the angle structures were not seen in situ, and only after indentation one could actually see all the angle structures. It's very important to make a mark about whether you see any blotchy pigments and synechia or not, because that is crucial to differentiate between primary angle closure suspect and primary angle closure. So she did not have any of that. So she had simple hyperopia, presbyopia, and primary angle closure suspect. It is, as I said, important to look for certain other signs apart from raised intraocular pressure to differentiate between PAC and PACS. And in patients with PACS, it is not necessary to do a PI. And why is it not necessary? If you look at certain evidence like this from Ravi Thomas, upon following up patients over a period of 5 years, only 11 out of 82 actually developed PAC. They did not develop PACG, so it was still possible to perform an iridotomy, do certain lasers, give medications if required, and prevent visual loss completely. So there is no risk of vision loss in these patients over a period of 5 years, and the harm of doing the surgery or the intervention PI is minimal. So you have to look at a balance between both to decide whether it is required or not. When you look at PAC, a lot more of these progress to synechial closure and developing glaucoma. So because there is a loss of risk of loss of field of vision and the harm is minimal, in PAC you need to do a PI. Also, the randomized control trial, the ZAP trial, basically established and closed the debate forever. And we can be sure that very, very few patients of PACS, whether you do a PI or you don't do a PI, are actually going to progress. And this incidence is so low that there is no advantage as such of performing a PI in patients with PACS. So what do you do then? You can keep following them up 6 monthly and perform an annual dilated examination. In our practice, we do either of these tests. After establishing that the baseline OCT is correlating, I prefer to do OCT for these patients. But there are certain indications where you need to do a PI in patients with PACS. If they are fellow eyes of acute angle closure, PAC, PACG, they need frequent dilatation. Now, this is written everywhere, but nobody tells you what frequent dilatation is. So anybody who requires dilatation any more frequently than 4 to 6 months, basically moderate or severe NPDR or worse, poorly controlled diabetes is a group that we we perform PI for. And patients who have difficulty in follow-up, patients who have family history of angle closure glaucoma, or as such in a population, someone tells you that my father couldn't see at the end of his life, that you have to, a retina specialist has to consider that that was an RD, a glaucoma specialist has to consider that that was a glaucoma and treat and prevent whatever risks of vision loss is there in those people. And one-eyed patients. These are precious eyes. Do perform a PI a little earlier than other people. In our practice, there are certain additional indications that we follow. A post-dilated rise in intraocular pressure is a possible suggestion that the trabecular meshwork is getting decompensated. Okay. A Van Herrick's grade 0, and if you require a significant force of indentation. So I'll just sum it up here, and I'll just very briefly present the next case, which I think is very, very important. So this is a 50-year-old lady who came to us for a second opinion because she was advised surgery, and she was on one PG analog in the morning and one PG analog at night when she came. Visual acuity in the right eye was good. Anterior chamber, both eyes were shallow, and left eye vision was not great, improving with pinhole, and she had a grade 3 relative afferent pupillary defect. Upon trying to indent, we realized that we required a significant force to indent open this angle. So if you are performing gonioscopy and indenting, don't stop till you see a concave indentation in the iris, which means that you have really pushed the iris back. And if it is not opening now, it is not going to open because there is synechial closure. And this lady, it was possible to open the angle partially, and we could make out a sine wave sign. I had a picture, but anyway. And I was at a center where I didn't have the opportunity to give mannitol with a pressure of 48 millimeters of mercury. So anyway, I gave a tablet of acetazolamide and told her to put pilocarpine in the eye twice in an hour. And you know, when she came back after an hour's time, not only did her pressure drop, I could see the angle much easily opening after the pilocarpine. And this is what pilocarpine can do in patients with plateau iris. So there are two messages here. One thing is, don't forget to do a gonioscopy after performing a PI. 50% of our population, the angle will remain closed. Some of them because of a large lens, but a majority of them because of plateau iris, the treatment of which is giving pilocarpine or performing iridoplasty for them. Thank you so much. I'll stop here.
Yeah.
Clinical identities that we meet in our regular practice. And now we have expert discussant Dr. Ganesh, who will share his valuable experience.
Yeah, thank you, Dr. Siddharth. I don't have slides, so I'll just speak the points which Siddharth has nicely covered. Just a few things to add. One important thing I feel is looking always at the refraction of the patient. So as the patient walks in, you look at the eye and then look at the refraction. Most of these patients will be slightly hyperopic, slightly more than what you anticipate. And the second thing is, of course, you should always examine the patient thoroughly. Look for the pupillary rough. That is another extra point which you could always think of. Pupillary rough will be absent in these patients. Sometimes patients present with iridocysis also. So when you have patients with absent pupillary rough or asymmetric pupillary rough absence, always think that there's something going on in the angle. And when you have iridocysis, there's another problem where to do the PI. So iridocysis can be associated with open angle as well as closed angle. So better always when you have iridocysis, do it in the area where there's no iridocysis. So that's something which you should always consider. And apart from that, the first scenario was the indications of LPI. So indications of LPI, if you have the acute attack in the one eye, the other eye definitely has to have it. Nowadays we see a lot of patients with ARMD. Now with the present treatment, many of them are 6'6". They walk in 6'6". They may not tell you they've got so many injections. So that's another thing which you have to think of. So the repeated dilatations, just not for diabetes, but also for ARMD. You have a very good treatment nowadays. They walk in, they don't tell you that they require. So that's another thing which you have to keep in mind. And apart from that, I think Dr. Siddharth has covered very nicely. Look for the sine wave sign. The force of indentation is very important. Angle recess is what you have to learn to assess. So if you have to open the angle too much and with apply too much force, with that you are opening the recess and you're seeing the sine wave sign, definitely those eyes require and there was a discussion, if the patient walks in and is on multiple medications and he's been referred to you, getting the pressure is not getting controlled, try a bout of pilocarpine. And pilocarpine, you can see the response within 5 days. You don't need 2 or 3 weeks or 4 weeks like other molecules. You can see the response in 5 days. The advantage of pilocarpine is if you switch it off, you take it away, the reversal also happens in 5 days. The washout effect is very fast. So you can always try pilocarpine before you take up the patient for any further management. Thank you.
Thank you, Dr. Ganesh. Any questions from the audience? Because we wanted the audience to come out with some specific doubts or additions or questions they have.
Was this course helpful, or we needed to do it slightly differently? Was it of use?
Technical glitches are not, under our control because, but yeah, thank you, Dr. Ganesh.
Panelists, do you want to put forward anything?
Would you like to add anything, Dr. Alokesh, Dr. Amit? And there's a question for Dr. Ganesh. Like, we have these OCTs these days. Can OCT replace gonioscopy? Because a lot of people have access to OCTs even in the periphery. Absolutely. And we see a lot of angle being imaged rather than gonioscoped. So
it just complements, it won't substitute. So you have to take it into that account. We have a lot of patients walk in with printouts of angles.
Exactly.
The printouts, and then they shove it under our nose and expect us to say something. So it takes away your thought process all of a sudden, because you're thinking on lines of treating the patient. All of a sudden this comes up and you have to interpret a report which you have not advised. So that's really not, etiquette wise, it's not very good. So why should I interpret a report which somebody else has asked to do it? The other person who has ordered it has to interpret it and give a report on that. So when that gets shoved under my nose, I get really upset. But then I control myself. I tell them that, okay, this is good. Take that report, explain to them what is abnormal, and then tell them what I have seen in the gonioscope.
I think just one I will add, because it's just one part of angle or one section of angle you are seeing, and we see sometimes there's a quite of difference in the angles once we view the gonioscopy from the superior to the inferior angles also.
Test variability is also there in the machine, and within the test
also.
And
this is usually a temporal.
Also matters.
This is usually a temporal or a nasal angle rather than the superior or the inferior angle. So I mean, just want to say that it's just one section, and we can't think about all the angles.
So we should not be doing that. And second thing, the patient should understand that also that we are looking at 360 degree, which of course difficult for us to tell them, because they think they got the whole thing because they paid a lot of money for that.
Yeah.
No, and there's a technician issue also, depending on the light falling on the pupil, or what was the illumination at that point.
Just I'll add a small thing. Look, imaging has progressed significantly, and KCR now will give you a 360 degree index of ITC or ideal trabecular contact. But what it will do, even when you see a closed angle there, it will tell you that there is primary angle closure disease. But what amongst that is whether it's a PACS which does not need a PI, whether it's a PAC which needs a PI, or if there is a plateau iris, because you cannot indent. That's the biggest limitation. You also have to do these imagings in a situation where you need light. So whether a PACS or a mild PAC is getting opened up just because of the effect of light falling on the pupil even in the other eye, so that's something that we have to be careful of when we are interpreting.
So our take-home message, I think, would be that this should be used as a diagnostic tool, but maybe to convince a patient that you should undergo a PI. Maybe that is where we need
to. Primary tool still remains the gonioscopy unless you want to cover up your charges for, say, CGHS or some other thing to add up.
So, Ankur, what you brought up, the AIOC picture.
I wanted to ask, like even Ganesh, Arijit, or Amit, or Ankur, or Sutandari, how would you say that after interpretation and reading of the ZAP study, has your number of peripheral iridotomies that you do, has it affected it?
No, these are the criteria which we used to follow earlier also.
No, I think we have reduced. For PACS we have reduced.
So format is the same.
Criteria which Dr. Siddharth has nicely pointed out. We don't do for PACS, we follow them up. But one caveat would be that supposing the patient is essentially normal and then he develops a systemic condition like hypertension or diabetes, immediately we do a PA. Because for one is diabetes, you require repeated dilatation. For hypertensives, they have a high tendency to develop vein occlusion with angle closure disease. So for those two, if they develop, we do a PA. But we have reduced.
Another thing is this, that they interestingly showed, I think, 3 cases in which, out of maybe 5,000, with a patent PI, when they dilated, there was acute closure, angle closure attack. So have you ever faced something? I have not faced, but I know.
Yes.
Yes, so that's what I was actually coming to. Is it was very surprising to see progression of PACS to PAC in patients even after a PI.
Thank you. Thank you, sir.
And that is all because all these trials, they don't segregate plateau iris from plagal closure.
Might be, yes.
If you club these two majorly distinct entities, exactly. So it's not just fluid
Dr.
pushing it,
Vijay,
if ciliary
get
body
ready.
is pushing it, then you can't treat that with just a PI. So that is.
I think we need to individualize each patient rather than talking about the statistics. Like looking at the family history, if the family history is positive for an angle closure and an aggressive angle closure in the family, the kind of follow-up the patient can have. I mean, these are all the things which I think of in planning of a PI, apart from the anatomic structure, what we look at.
Whatever is left of the team, we would like to take a picture
I think
together
I
and
thank
then hand
all
over
the-
the podium to
Yeah,
the
I
next.
thank everyone, all the panelists, all the discussants, all the presenters, and all the audience to stick on to us.